Surgical radiography. Medical asepsis is defined as any practice that helps reduce the number of spread of microorganisms. Surgical asepsis is defined as the complete removal of microorganisms and their spores from the surface of an object. The practice of surgical asepsis begins with the cleaning of object in question using the principles of medical asepsis, followed by a sterilization process. Any medical procedure that involves penetration of body tissue, an invasive procedure, requires the use of surgical asepsis technique. Skin preparation, including scrubbing at times, hair removal precede invasive procedures. This prevents the contamination of the operative site, thereby reducing the chances of infection. The radiographer may be responsible for the skin preparation in this department and must learn to perform this procedure effectively. The radiographer will be required to perform the diagnostic radiography in operating room where he must work without contaminating the sterile field. Sterile technique is a set of specific practices and procedures performed to make equipment in areas free from all microorganisms and to maintain that sterility. Surgical radiology is a dynamic experience. The challenges a radiographer encounters in the surgical suite are unique. Knowing the machinery and its capabilities and limitations is most important. In that regard, the radiographer can enter any operating room case, whether routine or extraordinary, and with good communication, be able to perform all tasks well. And understanding of common procedures and familiarity with equipment enables the radiographer to perform most mobile examination ordered by the physician. Surgical radiography can be challenging and exciting environment for radiographer, but can also be intimidating and stressful. Surgical radiology requires educated personnel familiar with specific equipment routinely used during common surgical procedures. It requires expertise in teamwork. Preparedness and familiarity with equipment are key. Standard health and safety protocols must be followed to avoid contamination and to ensure patient safety. These are the basic and the pieces come together in surgical radiology in distinctive ways. Surgical team. In no other time is a patient so well attended so during a surgical procedure. A surgeon, one or two assistants, a surgical technologist, an anesthesia provider, a circulating nurse, and a various support staff who surround the patient. These individuals, each with specific function to perform from the OR team. This team literally has the patient's life in its hands. The OR team has been described as a symphony orchestra with each person an integral entity in unison and harmony with his or her colleagues for the successful accomplishment of the expected outcomes. The OR team is subdivided according to the function of its members into sterile and non-sterile teams. Sterile team members. Sterile team members scrub their hands and arms, don a sterile gown and gloves over proper surgical attire, and enter the sterile field. The sterile field is the area of the OR that immediately surrounds and is especially prepared for the patient. To establish a sterile field, all items necessary for surgical procedure are sterilized. After this process, the scrub and sterile team members function within this limited area and handle only sterile items. The sterile team consists of the following members. Surgeon. The surgeon is a licensed physician who is specially trained and qualified by knowledge and experience to perform surgical procedures. The surgeon's responsibility include preoperative diagnosis and care, selection and performance of surgical procedure, and postoperative management of care. The surgeon assumes full responsibility for all medical acts of judgment and for the management of the surgical patient. Surgical assistant. The first assistant is qualified surgeon or residents in accredited surgical educational program. The assistant should be capable of assuming responsibility for performing the procedure for the primary surgeon. Assistants have to maintain visibility of the surgical site, control bleeding, close wounds, and apply dressings. The assistant's role varies depending on the situation, on the institution, and with the type of procedure or surgical specialty. Physician assistant. The physician assistant is the non-physician allied health practitioner who is qualified by academic and clinical training to perform designated procedures in the OR and in other areas of surgical patient care. Scrub nurse. The scrub nurse is registered nurse who is specially trained to work with surgeons and other medical team in the OR. Certified surgical technologists. The CST is responsible for maintaining the integrity, safety, and efficiency of sterile feed throughout the surgical procedure. The CST prepares and arranges instrument and supply and assists the surgical procedure by providing the required sterile instruments and supply. In some situations, a licensed practical nurse or RN may assume this role. Non-sterile team members. Non-sterile team members do not enter the sterile field. They function outside and around. They assume responsibility for maintaining sterile techniques during the surgical procedure, but they handle supplies and equipment that they are not considered sterile. Following the principles of aseptic technique, they keep the sterile team supplied, provide direct patient care, and respond to any request that may arise during the surgical procedure. Anesthesia provider. The anesthesia provider is a physician, anesthesiologist, or certified RN anesthetist who specializes in administering anesthetics. Choosing and applying appropriate agents and suitable techniques of administration, monitoring psychologic functions, maintaining fluid and electrolyte balance, and performing blood replacements are essential responsibilities of the anesthesia provider during the surgical procedure. Circulator. The circulator is preferably an RN. The circulator monitors and coordinates all activities within the OR, provides supplies to the CST during surgical procedure, and manage the care of the patient. Radiographers and radiographers. The radiographers' role in OR is to provide intraoperative imaging in a variety of examination with various types of equipment. Others. The OR team may also include biomedical technicians, monitoring technologies, and individuals specialized in equipment or monitoring devices necessary during the surgical procedure. Proper surgical attire. Surgical attire protocols may change from institution to institution, but should be available for review, understood, and followed by all staff members. Although some small variants of protocol exist among institutions, there are common standards. Large amount of bacteria are present in the nose and mouth, on the skin, and on the attire of personnel who enter the restricted areas of the surgical setting. Proper facility designs and surgical attire regulation are important ways of preventing transportation of microorganisms into surgical settings where they may infect patients' open wounds. Infection control practices also involve personal measures, including personal fitness for work, skin disinfection, preparation of personal hands, surgical attire, and personal technique. Daily body cleanliness and clean, dandruff-free hair help prevent superficial wound infections. Operating room attire. The OR should have specific written policies and procedure to proper attire to be worn within the semi-restricted and restricted areas of the OR suite. The dress code should include aspects of personal hygiene important to environmental control. Protocol is strictly monitored so that everyone confirms to establish policy. Street clothes should have never worn within semi-restricted or restricted areas of the surgical suite. Clean, fresh attire should be done at the beginning of each shift in the OR. Sweet as needed if the attire becomes wet or grossly soiled. Soiled surgical attire should be changed to reduce the potential of cross-infection. Blood stain or soiled attire, including shoe covers, is unattractive and can also be a source of cross-infection or contamination. Soiled attire is not worn outside of the OR suite and kits should be taken to remove soiled clothing immediately on exiting. OR suite layout showing restricted, non-restricted, and semi-restricted areas. ORs are restricted. Unrestricted zone, person may enter in street clothing. Semi-restricted zone, only persons dressed in scrub dress with hair recovered and shoes covered may enter. Restricted zone, only persons wearing scrub dress, shoe covers, and masks are allowed to be present. OR attire should not be hung in a locker for wearing a second time. Underclothing should be clean and totally covered by the scrub suit. Other aspects of proper attire include the following. Properly, figure 29-3 is Shradtech properly wearing an attire.
Protective eyewear. Occupational Safety and Health Administration regulations require eyewear to be worn when contamination from blood or body fluids is possible. Mask. Masks should be worn at all times in the OR but are not necessary in all semi-restricted areas. Shoe covers. Shoe covers should be worn when contamination from blood or body fluids can be reasonably anticipated. Shoe cover should be changed whenever they become torn, soiled, or wet and should be removed before leaving the surgical area. Cups. Cups should be worn to cover and contain hair at all times in the restricted and semi-restricted areas of the OR suit. Hoods are also available to cover hair such as facial hair that cannot be contained by a cup and mask. Gloves. Gloves should be worn when contact with blood or body substances is anticipated. Radiation badge and identification. Radiation badge and proper identification should be worn at all times. Personal hygiene. A person with an acute infection, such as a cold, open cold sore, or sore throat, is known to be a carrier of transmittable condition and should not be permitted within the OR suite. Daily body cleanliness and clean hair are also important because good personal hygiene helps to prevent transportation of microbial fallout that can cause open wounds infections. Proper image receptor handling in the sterile field. To maintain proper universal precautions, the radiographer must follow specific steps when handling an IR in the OR. Surgical technologies taking the IR. The CST holds a sterile IR cover open toward the radiographer. The radiographer should hold one end of the IR while placing the other end of the IR into the sterile IR cover. The CST grabs the IR and wraps the protective cover securely. Figure 29-5 radiographer and CST place IR into the sterile drape. Radiographer accepting the IR exposure. After the exposure is made, the radiographer needs to retrieve the IR. The radiographer must be wearing gloves to accept to cover the IR that has been in the sterile field or under an open incision. The protective cover is possibly contaminated with blood or body fluids and should be treated accordingly. The radiographer should grasp the IR, open the protective cover carefully away from himself or herself or others so as not to spread blood or body fluids, and then slide the IR out of the cover. The radiographer should dispose of the IR cover in a proper receptacle and remember to remove gloves before handling the IR or any other equipment because the gloves are now considered contaminated. If contamination of the IR occurs, the radiographer should use hospital-approved disinfectant for cleaning before leaving the OR. Principle of aseptic techniques. Only sterile items are used within the sterile field. Only sterile persons handle sterile items or touch sterile areas. Non-sterile person touch only non-sterile items or areas. Movement within or around a sterile field must not contaminate the sterile field. Items of doubtful sterility must be considered non-sterile. When a sterile buyer is permitted, it must be considered contaminated. Sterile gowns are considered sterile in front from the shoulder to the level of the sterile field and at the sleeves from the elbow to the cuff. Tables are sterile on only at table level. Radiographers should not walk between two sterile fields if possible. Radiographers should avoid turning their back towards the sterile field in compromised spaces. The radiographer should watch the front of clothing when it is necessary to be next to the patient. The radiographer must be aware of machinery close to the sterile field, including lead aprons hanging from the portable machine that may swing toward the sterile field. The lead apron needs to be secure if it's being worn next to the sterile field. The apron can easily slip forward when raising one's arm up to position the tube. A properly worn apron does not compromise the sterile field or jeopardize proper body mechanics. When positioning an IR under the OR table, the radiographer should not lift the sterile drapes above table level because this would compromise the sterile field. Figure 29-6. A radiographer correctly removes IR from now contaminated bag to a clean table, being careful not to brush contaminants from back onto self or others. The picture B, radiographer disposes of bag and removes contaminated gloves before handling the IR. Equipment. The radiographer must be well acquainted with the radiologic equipment. Some producers may seldom occur. The radiographer need not fear a rare procedure if good communication and equipment knowledge are in place. IR holders enable the radiographer to perform cross-table projections on numerous cases and eliminate the unnecessary exposure of personnel who may volunteer to hold the IR. In mobile radiography, exposure time may increase for larger patients, and a holder eliminates the chance of motion from handheld situations. Mobile image machines are not as sophisticated as larger stationary machines in the radiology department. Mobile fluoroscopic units, often referred to as C-arms because of their shapes, are commonplace in the surgical suite. Mobile radiography is also widely used in the OR. Cleaning of equipment. The X-ray equipment should be cleaned after each surgical case. If possible, the radiographer should clean the mobile image machine, including the base, in the OR suite, especially when the equipment is obviously contaminated with blood or surgical scrub solution. Cleaning within the OR helps reduce the possibility of cross-contamination. The X-ray equipment must be cleaned with a hospital-approved cleaning solution. Cleaning solution should not be sprayed in the OR suit during the surgical procedure. If cleaning is necessary during the surgical procedure, opening the cleaning container and pouring the solution in a rag for use prevents possible contamination from scattered spray. Gloves should always be worn during cleaning. The underside of the image machine should be checked to ensure contamination that might have splashed up from the floor are removed. Cleaning the equipment after an isolation case is necessary to prevent the spread of contaminants. All equipment that is used less frequently should undergo a true cleaning at least once a week and just before taken into the OR. Radiation exposure considerations. Radiation protection for the radiographer, others in the immediate area, and the patient is of paramount importance when mobile fluoroscopic examination are performed. The radiographer should wear a lead apron and stand as far away from the patient, X-ray tube, and useful beam as the procedure, OR, and exposure cable allowed. The most effective means of radiation protection is distance. The recommended minimal distance is 6 feet 2 meters. When possible, the radiographer should stand at a right angle, 90 degrees, to the primary beam and the object being radiographed. The least amount of scattered radiation occurs at this position. The greatest amount of scattered radiation occurs on the tube side of the fluoroscopic machine. It is recommended that the X-ray tube always be placed under the patient because of the significant amount of exposure to the facial and neck region. The X-ray tube should never be placed above the patient unless absolutely necessary. Figure 29-9, radiation safety with C-arm in the upper image, less radiation reaches the facial and neck region when the X-ray tube is under the patient. This is the recommended position of the C-arm. In the lower image, which is the right side, there is a greater amount of radiation reaching the facial and neck regions. The OR may have sign posted outside the room warning of radiation in use, or lead aprons required when entering this room. Lead protection should be provided for individuals who are unable to leave the room. The patient's gonads should be shielded with appropriate radiation protection devices during examination in which shielding would not interfere with imaging of the anatomy that must be shown. When using fluoroscopic equipment with the tube under the table, shielding should be placed under the patient. In addition, the source to skin distance should not be less than 12 inches, which is 29 centimeters. The radiographer is responsible for protecting himself and all person in the OR and special procedure areas from radiation. He is also expected to be knowledgeable concerning the areas that are sterile. He must protect sterile areas and the patient from contamination in the process of his duties. The most common types of imaging equipment used in the OR are fixed ceiling or table-mounted portables and image intensifiers or C-arms for fluoroscopy. The radiographer is responsible for making certain that any radiographic equipment used during a sterile procedure is clean and dust-free before use. Following are some guidelines for working in the OR special procedures area. Number 1. Overhead units must be cleaned with a disinfectant solution, and portable radiographic machines and image receptors to be used must be cleaned with a disinfectant solutions. Number 2. Sterile technique must be maintained for all times and persons involved in the invasive procedure. Number 3. If possible, place image receptor and thick scalp films before draping the patient for the procedure. Number 4, if the image receptors must be placed after the procedure is begun, the radiographer may pass the image receptor to the scrub nurse who received the image receptor in the sterile plastic bag and place it at the radiographer's direction. Number 5, if the radiographer places the image receptor himself, the surgical team must make room for him. He may place the image receptor by raising the sterile drapes touching only the inside of the drape, or the circulating nurse may lift the drapes and assist in placing the cassette into the image receptor holder. Number 6, if multiple images are to be taken, all personnel who are not scrubbed must leave the OR. If at all possible, the scrub members of the team must wear protective radiation apparel. They may also step behind protective lead line screens. The call out. The radiographer must wear his radiation detection badge outside of the lead apron while working in the operating room. Draping for Sterile procedure. Following the skin prep, for a sterile procedure, sterile drapes may be applied. These are used to provide a barrier to infection and also to create a sterile field on which to place sterile instruments. Using single use, single thickness, impermeable drapes are used. However, some cloth drapes may be chosen. Whatever the material on hand, the process is the same. A fenestrated drape is often used, and if so, the drape should be applied in such a way that the opening leaves only the operative site exposed. Sterile drapes must be handled as little as possible. They must not be flipped or fanned. If sterile towels are used, place them so that they are within the limits of the area prepared. They are folded so that they overlap and the folds face the operative site. If the radiographer is to place the sterile drapes, the procedure is as follows. Number one, place the pack of sterile drapes on the table in which are to be opened. 2. Open a pack of sterile gloves. 3. Open the packs as directed earlier in this chapter and don the sterile gloves. 4. Pick up the first drape holding the drape in such a manner that your sterile gloves are protected. Do not allow the drape to fall below waist level or touch the uniform. 5. Drop the drape in place and do not move it again as the underside is now contaminated. 6. Add additional drapes as required. If a drape is contaminated during the draping process, it must be replaced. Figure 5-24. Letter A. Folds of sterile towel must face operative site sterile glides. 5. B. Pick a first drape holding drape to protect. Skin preparation for sterile procedures. The radiographer may be called upon to prepare a patient's skin for an invasive procedure in the special procedures area. This is referred to as skin prep. The purpose of the skin prep is to remove as many microorganisms as possible by mechanical and chemical means to reduce the chances of infections. The antimicrobial agent used for this purpose may vary. However, it must prevent tissue irritation and the rebound growth of microbes. If hair removal from the site is indicated, it will be completed by the radiology nurse. If ordered, it is done as close to the procedure as possible to prevent growth of microorganisms. If no hair removal is required or is complete, the skin prep follows. For special imaging procedures, a commercial skin prep pack is used. Items the radiographer must have on hand are number one, sterile gloves if they are not included in a commercial pack. Number two, a sterile prep tray that includes a sterile drape, two small basins, and a set of large sponges with handles to distance the operator's hand from the site. The sponges are permeated with antiseptic soap, a flask of sterile water, and a flask of antiseptic solution as recommended by the physician. 4. A sterile towel. The radiographer proceed as follows. 1. Approach the patient. Explain the procedure and ascertain allergies to antiseptic to be used. Open the sterile pack as directed earlier in this chapter. 2. Pour the sterile water into one small basin and antiseptic solution into the other as directed earlier in this chapter. 3. Don sterile gloves. 4. Inspect the area of skin to be prepped for lesions or unusual appearance. If there is no problem, you may proceed. 5. Pick up one sponge permeated with antiseptic soap and dampen it in the sterile water. Then begin scrubbing the center of the area to be prepared. The physician will explain how large an area must be prepped. Usually an area approximately 6 to 10 inches in diameter is prepped. Work outward in a circular motion Using a firm stroke as friction is as important in the removal of microorganisms as the antiseptic soap. 6. Do not go back over the skin that has already been scrubbed with this sponge when the edges of the area being scrubbed are reached. Drop the sponge of the sterile field and repeat the procedure with a second sponge. Figure 5-23. Letter A. Work in a circular motion using a firm stroke from center outward. Figure 5-23. Letter B. Drop soiled sponge of field and repeat. Number 7. Following the scrub, rinse the skin well with sterile water or wipe away the lather without rinsing if that is institution's procedure. 8. Blot the skin dry with sterile towel. 9. Inspect the patient's skin during the screen prep. If the skin shows signs of irritation, stop the procedure and thoroughly rinse off the soap with sterile water and notify the physician. 10. Do not allow solution to drain off the area being prepped or to put under the patient during the procedure as this may burn the skin. 11. Following the initial scrub, the skin around the area to be penetrated is often painted with an antiseptic solution. This destroys some of the remaining microbes and act as deterrent to further microbial growth for a brief period of time. Agents commonly used to skin prep are hexidine and hexachloroquine. Alcohol is not used on mucous membranes or on open wounds as it may cause harm. 12. If the skin is to be painted after scrub, it is performed in a circular motion, beginning in the center of the area to be prepped and working outward. Allow the skin to dry. 13. If there are no long handled sponge available, 4x4 sterile sponges may be folded and grasped with a sterile ring forceps and dip into a container of antiseptic solution. Figure 5-23, letter C, paint skin in circular motion, beginning at center and working outward. Call out. Sterile technique is maintained during the skin prep for the sterile procedure.
Removing and reapplying dressings. If a dressing is to be removed or reapplied, there must be an order from the physician in charge of the patient. If an order has been obtained and a dressing is to be removed for a procedure, the radiographer must be able to remove it without contaminating the wound or himself in the process. All dressings must be treated as if they are contaminated because drainage from wounds may be harbor pathogenic microorganisms. Before removing a dressing, the radiographer will obtain a plastic bag for infectious waste, a bag closure, clean gloves, and drape sheet. The procedure is as follows. Number 1. Wash hands as per medical aseptic procedure. 2. Explain the procedure to the patient and place him or her in a comfortable position. 3. Provide privacy for the patient by closing the door. Keep all of his body covered except the area where the dressing is in place. Loosen the tape holding the patient's dressing in place and then don the clean gloves. It is difficult to manage tape while wearing gloves. Remove the tape with care. If it adheres to the skin and the patient complains of pain, use a commercial tape remover. Pull the tape up toward the wound while supporting the skin with non-dominant hand. Don the gloves and remove dressing carefully. Figure 5-25A. Be cautious when removing the dressing because it may adhere to the wound or there may be a drain in place. If the dressing does adhere to the wound, stop the procedure and call for assistance from the physician or the nurse. Do not forcefully remove a dressing. To do so, many damage tissues around the wound or dislodge a drain. Next. 6. Assess the dressing for drainage or blood when removed. Inform the physician if a large amount of either is observed. Place the soiled dressing into the bag prepared for it. Remove the gloves as previously instructed. 8. Place your hands under the cuff of a refused bag and unfold it upward. Close the bag with a closure and place it into a receptacle for contaminated waste. Last, wash hands. When the radiographer receives an order to reapply a dressing, sterile technique must be used. The procedure is as follows. First, assemble the necessary equipment and wash hands. Equipment needed is a sterile towel or small sterile drape, sterile dressings of the appropriate size and type, sterile container for normal saline if cleansing is necessary, sterile forceps, tape, a refuse bag enclosure, sterile gloves. 2. Approach the patient and explain the procedure. 3. If the soil dressing has been removed, remove it in a manner described above. Open a sterile towel or drape to double thickness and use it as a sterile field in which to place the sterile dressings. Open the dressings and drop them onto the sterile field without contaminating them. 6. Prepare the tape by having it cut or torn into lengths. Needed to keep the new dressing in place, place tape in a convenient place away from the sterile field. If plan includes cleansing the skin around the wound, pour, pour normal saline into the container prepared for it. Don sterile gloves. Cleanse the skin around the wound and sterile normal saline if necessary. If the following manner, fold gauze sponges and grip them with a sterile forceps. Moisten several of the gauze sponge and with normal saline and gently cleanse the skin, beginning in the area closest to the wound and moving outward. Drop soiled sponge into waste receptacle, being careful not to contaminate gloves. Repeat the process if necessary. Do not wash the wound and do not apply medication or antiseptics. 10. Allow the skin to dry, then apply new sterile dressing. If there's a drainage from the wound, apply additional dressing to absorb the drainage. Remove gloves and drop them into the refuse bag. Apply tape up to the dressing by applying pressure evenly on both sides of the tape away from the direction of the wound. Do not apply excessive pressure as it may traumatize the skin. Cover the patient and make him comfortable. Dispose of waste correctly.
Skin preparation for sterile procedures. Pour sterile water into one small basin and antiseptic solution into the other as directed earlier in this chapter. Pick up one sponge permeated with antiseptic soap and dampen it in the sterile water. Then begin scrubbing in the center of the area to be prepared. The physician will explain how large an area must be prepped. Usually, an area approximately 6 to 10 inches in diameter is prepped. Work outward in a circular motion using a firm stroke as friction is as important in the removal of microorganisms as the antiseptic soap. 6. Do not go back over the skin that has already been scrubbed with the sponge. When the edges of the area being scrubbed are reached, drop the sponge of the sterile field and repeat the procedure with second sponge. Following the scrub, rinse the skin well with sterile water or wipe away the latter without rinsing if that is institution procedure. 8. Blot the skin dry with a sterile towel. Do not allow solution to drain off the area are being prepped or to pool under the patient during the procedure as this may burn the skin. 11. Following the initial scrub, the skin around the area to be penetrated is often painted with an antiseptic solution. This destroys some of the remaining microbes and acts as deterrent to further microbial growth for a brief period of time. Agents commonly used for skin prep are chlorhexidine and hexachloroquine. Alcohol is not used on mucous membrane or on open wound as it may cause harm. For sterile procedure, do not allow the drape to fall down below waist level or touch the uniform. 5. Drop the drape in place and do not move it again as the underside is now contaminated. 6. Add additional drape as required. If a drape is contaminated during the draping process, it must be replaced.
CST holds a sterile IR cover toward the radiographer. The radiographer should hold one end of the IR while placing the other end of the IR into the sterile IR cover. The CST grabs the IR and wraps the protective cover securely. After the exposure is made, the radiographer needs to retrieve the IR. The radiographer must be wearing gloves to accept a covered IR that has been in a sterile field or under an open incision. The radiographer should grasp the IR, open the protective cover carefully away from herself. The radiographer should dispose of the IR cover in a proper receptacle and remember to remove gloves before handling the IR. If an order has been obtained and a dressing is to be removed for a procedure, the radiographer must be able to remove it without contaminating the wound or himself in the process. First, wash hands as for medical aseptic procedure. Second, explain the procedure to the patient. And place him or her in a comfortable position. Keep all of his body covered except the area where the dressing is in place. Loosen the tape holding the patient's dressing in place. Remove the tape with care. Pull the tape up toward the wound. Assess the dressing for drainage or blood when removed. Place the soiled dressing into the bag prepared for it. Remove the gloves as previously instructed. Place your hands under the cup of the refuse bag and unfold it upward. Close the bag with a closure and place it into a receptacle for contaminated waste and wash hands. When the radiographer receives an order to reapply a dressing, sterile technique must be used. The procedure as follows. Approach the patient and explain the procedure. Open the sterile towel or drape to double thickness and use it as sterile field on which to place the sterile dressings. Open the dressings and drop them onto the sterile field without contaminating them. Prepare the tape by having it cut or torn into lengths needed to keep the new dressing in place. Place tape in a convenient place away from the sterile field. If plan includes cleansing the skin around the wound, pour normal saline into container prepared for it. Don sterile gloves. Cleanse the skin around the wound with sterile normal saline if necessary. Allow skin to dry. Then apply new sterile dressing. Apply tape on the dressing by applying pressure evenly on both sides of the tape away from the direction of the wound. Cover the patient and make him comfortable. Dispose the waste correctly.